Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go get that free 31-page PDF on the top 200 drugs. Great study guide. You can do that at reallifepharmacology.com. Also, if you're looking for board certification study materials, different educational content for pharmacists, nurses, and other healthcare professionals, definitely go check out meded101.com/store. Tons of resources there, review courses, books, all sorts of different good stuff that can help you learn pharmacy, pharmacology, and other topics much better. All right, with that said, let's get into the drug of the day today, and that is Asenapine. Brand name is Safris, and this medication is classified as a second generation antipsychotic. As you could imagine, the probable uses for this medication that you're going to see out in practice are for bipolar disorder as well as schizophrenia. Now, mechanistically, again, I alluded to the fact it's a second generation atypical antipsychotic. With that, when you always hear somebody say that a medication is antipsychotic, you can likely suspect that it's got dopamine blocking activity, and indeed, Asenapine does have that. It's also got some serotonergic activity as well, serotonergic blocking activity at specific receptors, 5-HT1A and B, 2A and B, 2C, and 5 through 7 as well. So, again, there's kind of multiple modes of mechanisms with this medication. Again, the classification goes back to the dopamine blocking activity that it has. It also has some antihistamine type effects, as well as some alpha blocking effects as well. Again, those are lesser extents. They aren't as potent as other agents, for example. But when it comes to the side effect profile, we could recognize and understand that some of those other mechanisms, other than the dopamine blocking action, can present some problems or potentially contribute to some problems or have additive effects to other medications that may have similar mechanisms. So the serotonergic antagonism is kind of theorized to help lower the EPS risk, so that's the extrapyramidal symptoms, those movement-type adverse effects from antipsychotics. Also, it's potentially theorized to help with some of the negative symptoms of schizophrenia. So there are what's considered negative symptoms and positive symptoms of schizophrenia. So positive symptoms are the kind of outward things such as hallucinations and psychosis and some of the behavioral issues. On the flip side, the negative symptoms are more, I kind of think of things associated with depression. So, flat affect, lack of motivation, socially withdrawn. Those are some of the negative symptoms of schizophrenia. Moving on to dosing with this medication. So I would say Asenapine is unique in that it has a transdermal patch formulation. That's probably one of the most unique differences it has compared to a lot of the other antipsychotics. There aren't many. I'm actually not sure offhand if there's any with a patch formulation. So that is a potential, unique advantage of this medication compared to some of the other agents. Now, I will say in practice, it's been quite some time since I've seen this utilized. Typically in patients that maybe struggle with oral adherence, we may use sublingual, we may, have use of some of the long-acting injectable antipsychotics, which I've covered in some of the previous podcasts as well. So risperidone Consta, for example, is one of those medications that has a long-acting injectable where we give this medication. And then we don't have to give it for a period of a couple weeks or month in some cases as well for other agents. So again, that transdermal patch provides us with another opportunity or another route or dosage form administration technique. But again, in clinical practice, can't say I've seen it used terribly often, at least at this point. So let's talk more specifically. So we've got sublingual dosage form with this medication. Usual dosage range, initial, we may do 2.5 to 5 milligrams twice daily. Typical max dose is up to 20 milligrams twice daily, so we titrate that typically on a weekly basis, but we can, you may see clinicians get a little bit more aggressive depending upon the clinical circumstance and situation. The transdermal patch, we have two dosage forms. Or two dosages. We have a 3.8 as well as a 7.6, and typically we're going to wait a week at least to increase that patch dose if we're looking to get more aggressive control on the situation. All right, adverse effect profile, as you could expect, this medication being an antipsychotic, we've got to pay attention to the extrapyramidal symptoms. Akathisia can happen. So that's a movement disorder characterized by basically patients feel extremely like restlessness on the inside. Basically, they can't sit still is sometimes the way patients describe that adverse effect, and that certainly has been reported with asenapine here. Dystonia is another one that can happen as well. So this is basically kind of a sustained or intermittent muscle contraction that's involuntary, and it can cause some kind of unusual, twisting of the body and repetitive movements, or unusual kind of posturing or positions of the patient as well. So it can be certainly a very, very troublesome adverse effect. And then tardive dyskinesia, I wanted to describe that a little bit as well. So if you remember that tardive means delayed or late, dyskinesia, that refers to involuntary muscle movements. So as you could expect, these are, delayed onset adverse effects with that tardive definition there. And so there's typically a delay between when you start this medication and when you develop some of those involuntary muscle movements. As far as asenapine specifically, I guess I would call it middle of the road for some of these adverse effects compared to other second generation agents. So akathisia, dystonia, tardive dyskinesia risk, I'd probably consider it middle of the road, where some of the others are higher and some of the others are lower for this risk. All right, other adverse effects, asenapine, so endocrine risks, weight gain, hyperglycemia, increase in lipids, hyperprolactinemia has been reported as well. Orthostatic hypotension has been reported. Keep in mind, I alluded to the mechanism, so the alpha blocking activity, that could contribute to that orthostatic hypotension risk. Anticholinergic, it can mild to moderately block histamine type receptors, and we could have some mild anticholinergic type activity. Generally not too bad for this one compared to other agents. And then QT prolongation risk isn't terribly high either with asenapine. Other things to think about, patch formulation, obviously we can have some irritation at the site as far as adverse effects. Rare reports of blood disorders like leukopenia, neutropenia, agranulocytosis. Again, that's generally more associated with clozapine, but has been associated with other antipsychotics like asenapine as well. Rare neuroleptic malignant syndrome, often referred to as NMS or abbreviated as NMS. So elevation in fever as well as muscle rigidity. Typically, this is going to be soon after the medication started. Usually, higher dosages, younger patients may be more at risk for this issue here as well. And then, of course, we always have that boxed warning. It is an antipsychotic for use with elderly patients with dementia-related psychosis. They are at an increased risk of death. One last rare thing I will mention, seizure threshold may lower that potential, increase the risk for a potential seizure in patients that have that problem. Again, not crazy high on my list that I worry about, but if you got somebody with that history, you see asenapine started, utilized, and they have a seizure, shortly after, that type of thing, or with an increase in dose, that definitely is something to be aware of and pay attention to. From a pharmacokinetic standpoint, I wanted to mention the sublingual formulation and the transdermal formulation, particularly with thinking about those concentrations and when they kind of hit their maximum. So sublingual formulation, if we need a quicker onset, utilizing this over the transdermal definitely makes some sense, right? So sublingual, that Tmax, or the time that the time it takes for a drug to get to max concentration, that's going to be pretty quick. It's going to be within, a half hour, for example. Typically, we're going to get to that Tmax with that sublingual tablet, maybe up to an hour at most. That transdermal Tmax, that can take hours, numerous hours. So, half a day to a day even, to get to that Tmax with that transdermal, because it takes some time for a drug to get absorbed across the skin. So definitely a good thing to remember there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, NAPLEX, go check out med101.com/store. We've helped thousands of pharmacists pass their board exam and can absolutely help you as well. In addition, if you're a pharmacy technician, we've got a review course available on udemy.com, so you can go check that out, as well as numerous books on Amazon for nurses and other healthcare professionals as well. So go check that out. All those links at med101.com/store. All right, wrapping up with drug interactions. So first off, asenapine is considered a weak inhibitor of CYP2D6. Probably the most prominent drug interaction here is paroxetine. So paroxetine concentrations will actually go up when we add asenapine to a patient's medication list. So we may have to reduce that dose and recognize that this may be an issue. The medication itself, asenapine itself, is metabolized by CYP1A2, CYP2D6, and CYP3A4. The major pathway, or probably the most frequently used pathway, is CYP1A2. The biggest medication that I remember that inhibits CYP1A2 is ciprofloxacin. So Cipro could potentially increase the concentration of asenapine, and obviously that could lead to an increased risk for adverse effects, for example. Other things to think about as well: QT interval prolonging drugs, antiarrhythmics, for example, some of the antibiotics, macrolides, fluoroquinolones, citalopram, azole antifungals. These are all meds that can cause QTC prolongation, and on top of asenapine, we could increase that risk a little bit further. So again, typically we're just going to monitor that. If we know we've got a patient with that past history of a concerning QT interval, then obviously we need to pay a little bit closer attention to that. We're probably going to do EKG, maybe a little closer monitoring. If we feel a drug like asenapine is absolutely needed, that could bump that up a little bit more potentially. So definitely pay attention to that. Obviously, dopamine blocking agents, we can have some additive effects there. Metoclopramide, for example, is not considered in the class of antipsychotics, but has significant dopamine blocking activity, so we could have some additive effects there, and obviously increase the risk for some of those movement and extrapyramidal symptom type effects. CNS depressant, I'm not sure if I alluded to that, but certainly asenapine can be sedating as far as its adverse effect profile. This can certainly be increased by, opioids, Z drugs, benzodiazepines, gabapentin, plenty of medications there that can have that additive, sedative type effect. And then a couple things that I guess you can kind of keep on your radar, but I don't worry about to a tremendous extent. So additive anticholinergic burden. So let's say you add diphenhydramine on top of asenapine, that could potentially have a little bit more antimuscarinic, anticholinergic type activity. And then last, I'll allude to seizure risk. So you add a medication like bupropion on top of asenapine, that may lower that seizure threshold a little bit further. Again, generally, in your general population with no previous seizure history, is probably not crazy high on the priority list, but in patients who have a seizure history, they're taking, phenytoin or Keppra, for example, we may need to pay a little bit closer attention to that for sure. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor. Leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. Share us with friends, colleagues. We've got a library of, I believe, over 400 episodes, or around 400 episodes already. So go take advantage of that. You can search the website, reallifepharmacology.com, for all those. They should also be on your favorite podcast platforms as well. So, again, go check that out. Support the sponsor med101.com/store as well. Purchases there go directly to help support this podcast. And with that, if you have comments, suggestions, feel free to reach out, mededucation101@gmail.com. Or you can track me down on LinkedIn and connect with me there. Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care, and I hope you have a great rest of your day.